So coming up next, we have, where are we now? An update on new therapies for Parkinson's disease, Dr. David Lichter. I'm very pleased to have him here. Thank you so much.
Thank you, David. Good afternoon. So we're going to be covering today a couple of the newer therapies for Parkinson's disease. I don't know how many of you have been out to the exhibits outside and how many of you have heard about Embrisia. We're going to be talking about Embrisia for off periods in Parkinson's disease. Say a few words about an alternative medication which is not yet available, but hopefully will at some time in the near future, which is sublingual apomorphine. And then finally discuss something about medical marijuana. So off periods, as you know, are very common in Parkinson's patients, particularly after you've had Parkinson's for a period of time. About 40% in patients who've had it for about 5 years or so, but that gets up to about 70% after you've had Parkinson's for 9 or more years. They occur frequently. In one survey, about 70% of patients reported experiencing at least 2 off periods per day. And they actually also under-recognize, some physicians I think under-recognize off periods because they don't always, they're not always aware of the fact that off periods can be non-motor in nature as well as motor. So again, they are regarded as being troublesome in a large percentage of patients, and they can include a wide variety of both motor and non-motor symptoms. So that can mean that your primary motor symptoms of Parkinson's reemerge at some point. So that could be your tremor, could be muscle stiffness or slowness or difficulty walking. And also could be a whole range of other non-motor symptoms. So this slide showed you some of the more important, more common of those. Could be tiredness. A lot of patients tell me about mental clouding or fogginess, sometimes slowness of thinking as a non-motor symptom reemerging during their off phases. Sometimes it's a feeling of restlessness or muscle discomfort, aching. Other symptoms that you don't see in the slide can also occur. Some people develop anxiety or panic or shortness of breath or sweating during off periods. So all of these can be very troublesome. And there can be a range of different times when you experience those off-period symptoms. Perhaps one of the earliest types of off periods you can experience is early morning off. And that's because you go throughout the night, in most cases, without taking any of your medications. Now, in some patients later on, they may require another dose of their carbidopa-levodopa during the night, but certainly in the earlier stages, you don't. But you may feel slower or stiffer or have more tremor when you first get up in the morning. And then there are the wearing off symptoms, which occur at a variable time before your next carbidopa-levodopa dose is due. Sometimes it can be just a short time before, but other times it may be half an hour or an hour before, and that will definitely require a readjustment of your medications. Then this is this big category, and we're going to be talking a little bit more about this in particular, of delay to on of your next dose. So you take your next dose and you expect to switch on within a short period of time, 15, 30 minutes, but it may take an hour or longer for you to switch on. So that's a delay to on, and it's a big reason for considering this new medication if that is in fact the problem that you're having. And in addition to that, you can have individual dose failures where you may take a dose of your carbidopa-levodopa and not appear to benefit from that particular dose at all. Now, there are a couple of main reasons for developing these off periods over time with Parkinson's disease. One relates to the fact that you're losing dopaminergic neurons in the brain, so that there's no way of buffering. In other words, you're lacking ways of storing that dopamine which is derived from the levodopa that you take. But there's another big category of problems which can lead to these kind of symptoms, and that's related to the topic that Dr. Cloud talked to you about earlier on, which was this problem with the GI tract, which is, as you heard, involved very early in Parkinson's disease and where the problems seem to get worse over time, and particularly erratic gastric emptying and slowness of gastric emptying, which is so important if you're taking carbidopa-levodopa because the carbidopa-levodopa is not actually absorbed from the stomach. It has to get past the stomach and into the first part of the small bowel to be absorbed. So that is another major cause for this kind of problem. And this slide actually, the picture on the left-hand side of this slide shows you a nice example of this, where this particular patient with Parkinson's disease was having a gastroscopy for some reason. And this was an hour and a half after he had taken his tablet of carbidopa-levodopa, and the doctor saw with a scope there this tablet still sitting in the stomach an hour and a half after he had taken it. So clearly he was not benefiting from that particular dose. So anything which delays gastric emptying obviously is one potential cause of significant off-period time. This may seem like a complicated curve, but the graph, but the main reason for showing this is that this was a study that was done in 15 different patients. Each of these spaghetti curves represents one of those patients. And you can see there's a huge difference from one patient to the other in terms of what their peak levodopa level in the blood was after they took their dose, how soon the levodopa was observed to rise in the blood after their dose, and how long that level was sustained for. So you can see the first curve that you see to the left of this graph, this patient had a very abrupt onset of levodopa that was detectable in their serum after their dose, achieved a very high peak, and it kind of fell off as you'd expect over time with the carbidopa-levodopa. On the other hand, if you look at the peak which is furthest to the right on that slide, this patient had no evidence of levodopa in his system at all for the first 90 minutes after he took his dose, and then the peak went up. Now, normally you might expect that that patient would have had a dose failure, and he certainly had a prolonged time when he had no benefit from the dose. Eventually it did rise, and then you can see all of the differences between those two. So you can have, and this may vary in an individual patient from time to time during a day or during the course of several days too. They may have a response which is much better some days than others. The influence of dietary protein is clearly important because we know that dietary protein can interfere with the levodopa absorption. In this particular study, they took account of that. They made sure that all patients had their dose at least 1 hour before they had their meal, or at least 1 hour after their meal. So they tried to remove the effect of dietary protein from this kind of fluctuation. But you can see despite that, you can still have significant problems of absorption related to this delayed gastric emptying or erratic gastric emptying. And this is where this new medication comes in. How many of you have heard of Inbrija, inhaled levodopa? Very good. There's certainly people outside who are more than prepared to talk to you a little bit more about this, but to give you the basics of this, this is an inhaled form of levodopa which is now available specifically for off periods in Parkinson's disease and in patients who have been treated with carbidopa-levodopa. So the idea behind this is that it uses a totally new technology called ARCUS technology, which transforms the way the molecules of levodopa are arranged so that they differ in terms of their size and shape and configuration, which allows you to inhale what would formerly be an oral compound down into the depths of your lungs with a single normal breath, bypassing the GI tract and therefore bypassing this problem of delayed gastric emptying. So this is the technology behind Inbrija, which allows these molecules to be transformed so that in fact the particles may be a lot larger than they would be in their native state, up to 10 times larger, but at the same time they're a lot less dense, perhaps 90% less dense. And I like this diagram because it shows you the difference between a dandelion on the left and a puffball on the right. So it's the same compound, but this ARCUS technology transforms it so it may be much lighter, much less dense. It enables that same compound in its altered form to get down with a single normal breath into the depths of your lungs and be absorbed there into the systemic circulation and from the bloodstream then into the brain. So this was the primary trial which was done using this Inbrija, and it shows you on the top the placebo response. So patients were either allowed to continue with their normal medications and were given a placebo form of Inbrija, or they were actually given the active compound. Then they looked to see, they were evaluated when they developed their first off period, they looked to see how they responded to Inbrija or placebo after a single dose of Inbrija. And you can see that there was a placebo response, as we see in all our Parkinson's studies, so that the placebo patients did improve a little bit after their placebo form of Inbrija, but there was a much more significant improvement in those who took Inbrija, which started to be seen as early as 10 minutes after the dose, but where there was a very significant difference 30 minutes after the dose, and then that was sustained up to 1 hour, where there was a significantly higher likelihood of you being still in your on point after 1 hour if you were in the Inbrija group. So what is the safety of this drug? So there were safety considerations done in the original trial, but then there was this open label study. They wanted to see over a longer period of time people taking Inbrija, how they did. And this shows you the main kinds of side effects that were seen in patients over a period of time taking Inbrija. And the main one, as you can see, is cough, which is not too surprising because you're inhaling a compound into your lungs. They actually did not include patients with COPD or asthma or other chronic lung disease in these trials, and it's generally recommended that you don't offer this drug to patients who have those kind of lung disorders. And then there were a variety of other kinds of side effects in small numbers, which were seen actually in both the placebo and the active drug group. And you can see that there were a small number of dropouts in the Inbrija group, and cough represented some of those. There were a couple of patients who actually had hallucinations as well. And there are other kinds of side effects, one which may be discoloration of your sputum because this levodopa can be oxidized if it's exposed to body fluids, so sometimes the sputum can be a little darker than usual, and that can sometimes apply to other body fluids as well. But this is now a technology which is available. We can use it for patients who have any kind of off period. In the trials, it was made available for patients. You could use it up to 5 times per day. The average number of times per day it was actually used by patients in trials was twice per day. But it can be used up to 5 times per day. It can be used during the nighttime or during the daytime. As you can see, as I mentioned, it start to have its benefit within 10 minutes, although you'll see the major benefit after about 30 minutes. And the other interesting thing to note in this study was that only 1 out of, I think, 260-something patients, it was like 99.8% of patients were able to administer this themselves during their off periods. And I think the secret to that is that they instructed patients to take this when they started to recognize that they were entering an off period. You know, not to wait until they were in the very depths of their off period where they couldn't move and had very poor hand, coordination to wait to take the Inbrija. So you should take it if you, everybody will know what their off periods are like. When you started to enter an off period, this would be the time, to take that drug. Okay, so if there are any questions related to Inbrija, we can certainly answer them later, but I wanted to briefly switch from Inbrija to another drug which is being developed for exactly the same reason, to treat troublesome off periods in Parkinson's disease. How many of you at the moment are taking apomorphine as the injectable form of apokine? So none of you. Okay, so apomorphine is a very potent dopamine receptor agonist, so it's in the same class of drugs as pramipexole, Mirapex, Ropinirole, Requip, and Nupro, the rotigotine skin patch, except it's given, up to this point, it's been available to give, in this country anyway, only as a subcutaneous injection. And it's very effective, but it has the problems that injections have. Some people just don't like the idea of taking an injection. This is being developed as an alternative. It's a sublingual film of apomorphine which you put under your tongue. And in the 12-week double-blind trial which has been done with this drug, it showed results which were actually fairly similar to the Inbrija results we just saw. So within 30 minutes, there was a very clinically meaningful reduction of off-period symptoms. The benefits were actually seen with this drug starting at around 15 minutes, and they continued out to about 90 minutes. So also there was a much higher percentage of patients, as you'd expect, who developed what they called a full-on response to sublingual apokine compared with the placebo group, and it was well tolerated. Most side effects were mild to moderate and reversible. At this point, however, as of January of this year, the FDA has declined to approve the sublingual apomorphine film for treatment of Parkinson's disease in its current form. It's requested additional information. Interestingly, it hasn't requested any new clinical trials. But there is still a lot of interest in the development of this product, and the pharmaceutical companies trying to bring it to market is now recruiting for a larger scale, multi-site clinical trial as an extension study, which is aiming to focus on the safety and tolerability long-term of this particular product, and also to look to see whether it can be given without an antiemetic. If you use apocrine by injection right now, you have to use Tygan, certainly when you start using the drug, before you give yourself the injection, because one of the side effects can be nausea and sometimes vomiting when you take apomorphine by injection that way. So with this, they're looking to see whether with this product, so far it's been shown to have minimal side effects, if in fact they can give it without any drugs such as Tygan. So I think we haven't heard the last of this. Right now, as I said, it's not been approved, but my suspicion is that eventually it will be. So we had a question earlier on about medical marijuana, and I know it certainly cropped up. There were a lot of questions last year about medical marijuana, and we didn't have any kind of formal presentation on it. So I just wanted to give you the state of the art or knowledge as it is at the moment, which is still quite limited, as you'll find out. So there are a number of different medicinal properties of cannabis. They're related to two main cannabinoids. One is tetrahydrocannabinol. That's the product which is present in high doses in the recreational form of marijuana. And then there's cannabidiol, which many of you will have heard about and which you can purchase yourself, which acts on a different receptor. So the THC binds to the CB1 receptor in a variety of different regions in the brain. That's the psychoactive form. CB2 is the receptor for cannabidiol. It's found in more restricted brain regions, and one of the regions is in the pain pathways in the brain stem. So, in its unprocessed form, these two different cannabinoids are present in different concentrations in different species of the plant. I showed the two species on the first slide. The sativa form of the plant contains the higher concentrations of THC, the psychoactive form. This indica form of the plant contains higher concentrations of the cannabidiol. And depending on the ratio of those two cannabinoids, you're going to have different effects, both in terms of the psychoactive properties and potentially in terms of the effects of these cannabinoids on different brain systems. And that's been one of the many problems with the studies so far, is that they've used different formulations of cannabis. So this is just a summary slide which shows you, in fact, that in particular, tetrahydrocannabinol acts on a wide variety of different brain regions, from the higher areas of the cortex, which are involved in thinking and memory, to certain areas of the brain which are more involved in motivation and mood, to other areas which are involved in the ability to vomit. Obviously, you have to vomit if you're exposed to some kind of toxin, so that's where antiemetics act, to areas of the brainstem that I mentioned, which are important in pain pathways, to areas of the cerebellum involved in coordination. And what we're interested in is in areas of the basal ganglia, which are involved in motor planning and motor execution. And this slide suggests that it's the THC form of marijuana which has its main effects there. And up until recently, that was what the evidence suggested, that cannabidiol did not actually act there because the CBD2 receptors were not found in that area of the brain. But since then, there's been at least one study which has suggested that cannabidiol can act on different receptors in that motor area of the brain, which are G protein related receptors, not actually the CB2 receptor. So it is possible that both of these cannabinoids do act in the motor areas of the brain, but by different mechanisms. So before we come on to the data, of which there's a relative paucity of data, I just thought it might be interesting to share with you some of the beliefs of providers at National Parkinson Foundation Centers of Excellence about what they thought about marijuana before having the discussion of marijuana with their patients. This slide was was in 2016, so a few years ago now. But as I mentioned, there hasn't been a whole lot of research done on marijuana even over the last 3 years, so I suspect the data is not too dissimilar from this. But you'll see that there were actually, I think it was 56 providers here who actually responded to this survey. They were all providers who had been in practice for at least 1 year, so they didn't allow kind of interns or residents to respond to the survey. A large number of them had actually been in practice for 10 years. And you can see that most of them got their information from the medical literature, which is good, except we'll show the weaknesses of that literature in just a moment. But there were a number of other different ways that they got their information. Some got their information from personal experience, which is fine too, if you have personal experience. Not many of them did. Some got their information from other sources, including CME classes. Not many of them, though, had had formal training on medical marijuana in medical school or anywhere else, and I think that's probably the same, that's probably true even today, unfortunately. Some of them got the information from colleagues, some even from family and friends, and from a variety of different sources. So this just shows you that, unfortunately, to date, the training of doctors and other professionals on medical marijuana is kind of lacking, and people have had to rely on other ways of getting information. Now, this is also an interesting slide which shows you the beliefs based on those sources of knowledge of these providers at NPH Foundation Center of Excellence on the symptoms that they thought might benefit from medical marijuana, those that they thought the marijuana probably would have no effect on, and those motor and non-motor symptoms which they thought actually where it might make things worse. And though the histograms in blue are the number of providers who thought that that particular symptom would be improved by medical marijuana, the histograms in green are those where the provider thought that that particular symptom would not be helped or hurt by medical marijuana, where there'd be no effect one way or the other. And those bars in red are the numbers of providers who thought that particular symptom would actually be made worse. And so on the left, you see those symptoms which a majority of the providers thought actually might be helped by medical marijuana. And these are not too surprising from the literature. So we know that pain, for example, is one of those conditions which we have good evidence to believe based on both the way that marijuana works on pain pathways in the brainstem and on other studies which have been done in other disorders, not just Parkinson's disease, that there may be some benefit. As an antiemetic too, certainly some basis for belief that it might have that property. There were some doctors here who thought that it might have some effects also improving anxiety, and about half of them thought that it might help with tremor. The other half thought that tremor probably would not be helped. Some other motor symptoms, they were not so clear that medical marijuana would help. There were a variety of different non-motor symptoms that the providers didn't think would be particularly helped one way or the other. They also thought that bradykinesia would not really be helped significantly. And then there were the symptoms where they thought the medical marijuana could potentially make things worse, and you can see what those symptoms are on the slide. They include fatigue and motivation and sleepiness, symptoms of psychosis and so forth. So they had a number of concerns about side effects of this drug also. Now, as I said, most of them based this information on the medical literature, and this basically is the medical literature. You won't be able to read this slide, but I'm going to go through it in a little detail for you. The first thing to notice is the small number of patients. If you look down that second column there, when Dr. Gattuso was giving you his talk, you could see that often in controlled clinical trials, you might randomize 100 patients, perhaps 200 patients to one arm, and a similar number to the placebo arm, if you're doing a really rigorous randomized double-blind placebo-controlled trial. Here, there were 4 double-blind placebo-controlled trials, which are all at the bottom of the slide, and you can see even in those trials, the largest number of patients was 21. And that included across all 3 arms of the trial, so 7 patients in each of those 3 arms of the trial. That's the most robust data we have. And the other data is at the top of this slide, again with small numbers of patients. The top 2 are just surveys, and obviously there are weaknesses of surveys. These surveys did suggest that some patients were gaining both some motor benefits and some non-motor benefits of the drug. Then there was this very small case series of 5 patients which did show some benefit. I'm sorry, I'm having trouble reading this. Which showed no benefit of tremor. There was an open label case series in 22 patients that was done after that, which showed kind of differing results. So you can see this conflicting data from one study to another, and it's partially related to the way I think that cannabis was provided, and that's shown a little bit later on down here when you look at some of these studies which use smoked cannabis on the top. Now we're getting down into the lower studies where they use cannabidiol for some of these trials. Some of those trials looked at non-motor symptoms. So there was one study which looked at psychosis in a small number of patients. Actually, those patients in that very small trial seemed to benefit in terms of PD-related psychosis, despite what the providers at the NPH Foundation centers thought might happen. There was another trial in a very small number of patients that looked at REM sleep behavior disorder. Those patients seemed to improve a little bit. But then when you come down to the small number of patients involved in the randomized double-blind placebo-controlled trials, you also see this big divergence of results, and partly related to the product that was used. So that first study on only 5 patients was done with this drug, nabilone, which actually is an agonist, so it stimulates the same receptors that both THC and cannabidiol act on. The study below that, which showed differing results, was done with a different formulation of the drug, but one which also combined CBD and THC. In that particular trial, although there was no major benefit, I should say that the trial before that was looking at dopa-induced dyskinesias. And in that study, there did seem to be some evidence of benefit for levodopa-induced dyskinesias. In the larger trial, with 17 patients that you see listed there, there was no benefit of levodopa-induced dyskinesias at all, using multiple different measures. And there was also no benefit for a range of other non-motor symptoms. However, one of the problems with that study was that 71% of the patients accurately predicted or accurately able to share with the investigator which arm of the study they thought that they were in, whether they actually thought that they were getting the cannabis or they were getting the placebo. So clearly, if they knew what they were getting, you can't regard that as a placebo-controlled study, even though it's listed as such. The second bottom trial here was done with a product which actually blocked the receptor that THC acts on. You might expect that if THC is working to do some good and you block that receptor, it's going to have some disadvantage for the patient. There were no advantages or disadvantages in this small trial. The bottom trial is probably the most robust of the control trials that I could point to, even though, again, it's only 21 patients. So as I said, only 7 patients got placebo, 7 patients got a low dose of CBD, and 7 patients got a higher dose, 300 milligrams per day of CBD. And in this particular trial, although there were no benefit for the motor symptoms of Parkinson's disease, there were some other benefits, so improvements in quality of life and activities of daily living seemed to improve despite lack of definite motor benefits. So that's one thing to keep in mind, particularly at the higher dose they saw. This is the 300 milligram dose of cannabidiol. So, but this shows you the kind of problems that we've had with the medical literature of medical marijuana so far. Very small numbers of patients using cannabis in different formulations, many of them being unblinded studies, some just simple surveys. And so what really can we take away from this? Really, the main takeaway message is we need better designed trials and much larger numbers of patients. This is one other trial which wasn't listed on that list because this is a more recent survey. This is actually an Israeli study which was done, published in 2017. So they wanted to report what real-life patients' experience was. Now, in this particular trial, the majority of the patients were actually smoking marijuana. So this was inhaled cannabis with cigarettes, I think was 91%. 13% were taking it as in an oil formulation. Some were taking it in more than one formulation. Some were taking it by vaporizer form. So there's a variety of different ways, again, in this trial that they were taking it. But I just wanted to emphasize this study because although it showed some benefits in people who were taking marijuana this way for at least 3 months on some of their motor symptoms, and this study showed at least medium effect sizes, so moderate benefits for tremor, stiffness, and non-motor symptoms like pain, depressed mood, and sleep problems, insomnia. If you look at the table on the right, there was a kind of a cost for those benefits also. So 17% of the patients developed confusion, a similar percent developed anxiety or hallucinations, so 17% with each of those particular non-motor side effects. A smaller number of actually developed psychosis, but any kind of psychotropic adverse effect was seen in about 38%. And then there were a number of different physical side effects, including cough. That would be not too surprising if you're thinking about patients taking marijuana by cigarette form. But other physical symptoms, which amounted to close to 45% adverse effect rate for physical symptoms, and then any kind of adverse effect, whether it was physical or psychotropic, in close to 60% of subjects. But now you have to keep in mind that the majority of these patients were taking marijuana in cigarette form. But it's something you have to keep in mind. There are potential benefits, but there are also potential side effects. I had the pleasure of talking to somebody amongst you at lunchtime, and she told me that she was given by her neighbor a marijuana brownie, and it actually took away her tremor. Unfortunately, she ate the whole brownie and it was on the floor for 12 hours, completely out of it. So she was not advised by her friend that she shouldn't eat the whole brownie. So I think, obviously, dosing is very important. So now, in New York State, you can be prescribed medical marijuana for Parkinson's disease, as you can for a number of other neurological conditions, but it does come with some qualifying conditions that you need to meet if you're going to be prescribed medical marijuana for Parkinson's disease. So in addition to your Parkinson's disease, you need to have one of the other items which is shown on this slide, the most common of which would be either significant weight loss or significant pain. So severe or chronic pain or severe or persistent muscle spasms. There are other conditions too which normally a Parkinson patient wouldn't meet but would allow you to get medical marijuana. There could be severe nausea, seizures, PTSD, or if you have an opioid use disorder. Those are just the requirements in New York State. It doesn't apply in other states. So you need to keep this in mind, that if you're just presenting with your usual symptoms of Parkinson's disease and you don't have one of these other qualifying criteria, the person who's evaluating you probably will not be able to make this available to you. But the steps to prescription would be that you'd first of all discuss with your practitioner whether or not he thought that you might have some kind of symptom which might perhaps benefit from medical marijuana, allowing for the fact that our knowledge base is limited, as I've told you. Then you obtain certification for that drug from a practitioner who's registered to prescribe it in New York State. You register online, and then you purchase the product from a registered organization's dispensing facility. And that's the other aspect, as I'm sure many of you know. You do have to pay for this. This is not something which is covered by your insurance. So can I just ask, I'm actually interested in how many of you have ever tried medical marijuana for your Parkinson's? And just keep your arm up if you think you've benefited from it, or if you're still taking it for some reason. Okay, so at least 3 people in the audience. Okay. Not benefiting from it, or? Okay, a little shake of the head there. All right. I think that's all that I have to say about medical marijuana, but if there are any questions, either on this or on Breach, I'd be happy to answer any questions.
Before we get to the questions, I do 2 quick statements I want to make. That the stance of our foundation on medical marijuana is that precisely what Dr. Lichter was stating, is that there just isn't enough evidence, enough data for our foundation to promote its use, to condone its use. Now, we also recognize that we're in a predicament where we have a chronic, progressive, incurable disease, and so we would never tell somebody not to try it. If you qualify for it, if you're able to get a prescription for it, you know, we would never tell somebody not to try it, because we're certainly open to all avenues that could benefit somebody. But just to make it clear that our foundation at this point believes there isn't enough evidence to tell us that over the long-term use that it is safe. And so it's something that we don't condone, but we would certainly not tell somebody not to try it if we thought that it was going to help.